Hey, this is Dr. Allo. So one question I get a lot from ER physicians and a lot of my residents and friends that work in the ER is what pressors should I start? So not all pressors are the same. But here's like a quick rundown. Obviously, I'm not the physician evaluating the patient, and I'm not the cardiologist on call or the critical care physician on call. Talk to them and see what they prefer. But as a general guideline, if the person has a low heart rate and you want to get it up, and assuming they're not in third degree heart block, you can use dopamine. Dopamine will just bring their heart rate up and not really affect very much else. That's really simple. Now, if you give them atropine and dopamine, their heart rate's not coming up, and they're probably in some kind of third degree heart block or some really high grade AV block, or it has to be something infrahisian, below the His bundle, not going to respond. His and below, or like the AV node and below, is not going to respond to anything. If somebody is septic, you mainly want to use Levofette. Levofette is great for sepsis. It's been shown in all studies to do that. That's an alpha constrictor. It won't raise their heart rate. It's pretty neutral in terms of heart rate, but it brings up their pressure nicely. Obviously, follow the rest of the sepsis guidelines. If the patient needs a really strong alpha constrictor, then phenylephrine is your friend. Phenylephrine is the strongest alpha constrictor we have. Probably not going to be used much in the ER, but more for critical care. If the patient has a really low ejection fraction, like 10, 15, maybe 20%, and you think they're in cardiogenic shock, the best one to use is Dobutamine. A lot of times we'll put somebody on Dobutamine. That increases the strength of the squeeze. So Dobutamine would be the best option for that. Now, the last option is epinephrine. You can start someone on epinephrine or an epi-drip if their heart rate is low and their blood pressure is low and everything else is not looking good. You can put them on epinephrine. Now, epinephrine is the strongest of all the pressors, and it activates all the receptors, alpha 1, beta 1, alpha 2, beta 2, and it activates almost everything. So once you put them on epinephrine, you can drop the phenylephrine, the Levofette, the dobutamine, the dopamine, whatever else options you have. Now, let's say you put them on epinephrine, they start having a lot of VTAC. Okay, that's the problem with epinephrine. The problem with it is it's very arrhythmogenic. It can cause, especially someone that has CAD or really low ejection fraction, it can also cause arrhythmia. So just be careful with that. And that's pretty much it. Those are the main pressors you're going to use, and those are the main reasons why you're going to use them. I hope you enjoyed this video. Share it with all your friends.